I want to share with you some of many alternative ways to make diagnoses in psychiatry. And when I say alternative, I mean alternative to DSM. Because all the steps we do, all the steps we take from a treatment perspective depends on actually the right diagnosis. Now, the problem with the way we make diagnoses in psychiatry is that DSM is not really a diagnostic manual, and I'm going to explain what I mean by that. If you Google the meaning of diagnosis, or if you check in a dictionary, so this is from Google. It says the identification of nature of an illness or other problem by examination of the symptoms. Now, focus on identification of the nature of an illness. In the medical field, usually a diagnosis entails a linear causation, meaning this is caused by this, that is caused by that, and so forth, so on, up to a point. Now, DSM diagnosis, with exception of dementias and probably the movement Parkinson's disease that we cause with our drugs, we don't have a linear causation. We don't have an explanation of the nature of the problem. In DSM, we only have syndromes. So what's the difference? So again, I Googled syndrome definition, and what it says is a group of symptoms which consistently occur together, or a condition characterized by a set of associated symptoms. So let's see if we can understand this thing very well. Let's take some examples from the medical field. Let's start with an actual disease, let's say diabetes. So the symptoms of diabetes could be blurry vision, frequent urination. Behind that presentation, we have a line of events, a line of causation. So what causes the blurred vision and the frequent urination? No, elevated blood sugar. Well, what causes elevated blood sugar? Well, insulin resistance. What causes insulin resistance? Obesity, dietary factors, and what causes that, and so forth, so on. Now, we may not have a final answer for stuff, but we usually have a chain of factors, and that's how we define a disease. We go so far as having some knowledge on the biological mechanism behind it. We have some idea of the causes of what we're looking at. We also have medical syndromes, actually. So, for example, I have one here, acute abdomen. All right, so I'm going to read for you the signs of, and just bear with me, everything's going to make sense at some point. I'm going to read the signs and symptoms of acute abdomen. So we have severe abdominal pain, the tenderness, nausea, vomiting, not wanting to eat, fever, and diarrhea. Now, picture someone you love, a child or your spouse, going to the emergency room with you, having all those symptoms, all right? Your spouse or your child, someone you love, has all those symptoms. And then the doctor examines and he looks at you and to your kid or something says, I know what you have. You have acute abdomen. So let's assume you know nothing of medicine for a second. One question you could possibly ask would be, how do you know it's acute abdomen? Well, and you'd be probably very unsatisfied if the answer was, well, because he has abdominal pain, the abdomen is tender, has nausea, vomiting, doesn't want to eat, has fever, and has diarrhea. You wouldn't be satisfied with that, because another question you would ask was, well, what causes it? What causes acute abdomen? And that is the actual question that matters. That is, okay, what is the true diagnosis? What is the thing causing this presentation? And that could be a suppurated gallbladder, could be appendicitis, It could be ischemia, mesenteric ischemia, like some vascular event, and you have like necrotic tissue over there. So there are syndromes in all medical arts, but they have a clear distinction between what is a syndrome and what is a disease. Let me give you an example of another syndrome from the medical field, fibromyalgia. So you go to a doctor and you have pain, some trigger points, and you have tiredness, and you say, what do I have? And he's going to say, you have fibromyalgia. But that's just, fibromyalgia is the same as saying you have pain in those trigger points and you feel tired all the time. I already knew that, doctor. I want to know what's causing it. And for the sake of fibromyalgia or whatever attempts to describe it and neurophysiology behind it, we don't know. We don't know what causes fibromyalgia. So fibromyalgia is just a syndrome. So, doctor, I have pain these points in my body and I have fatigue. What do I have? And the doctor answers, you have pain in those parts of your body and you have fatigue. That is a syndromic diagnosis. The fact that you take that group of things and give a different name, you have John Smith's syndrome, Mr. John Smith, doesn't change anything. I hope that's clear. So how does that work in psychiatry? So you hear voices. Okay, I think I know what you have. You have schizophrenia. How do you know? Because you hear voices. Okay, why do I hear voices? Because you have schizophrenia. But how do you know I have schizophrenia? Because you hear voices. We call that a tautology, right? So, unfortunately, DSM is a huge manual of fibromyalgias. We just gave a name for a cluster of things. But giving a name for a cluster of things doesn't imply that we know what's behind it or that there is anything biologically meaningful from a causation perspective behind it. It's part of a chain, obviously, like everything else. And that is very heartbreaking. It's a funny thing that we have a very low inter-rater reliability, right? Which means we usually don't agree very much on the diagnosis that we have. And that is a consequence of syndromic diagnosis. It's a natural consequence. It's subject to all kinds of biases. If you take, for example, inattention or impairment in attention and restlessness, you're going to find those two symptoms present in ADHD, generalized anxiety disorder, bipolar, and major depressive disorder. So someone with those two main complaints presents to 4 different doctors, he can come out with 4 different diagnoses. And that's what we call a low inter-rater, different raters, reliability. Means the syndromic diagnoses just are not quite well described. Not surprisingly, the best inter-rater reliability we have in DSM is for the dementias, because dementias are actual diseases. We have some knowledge of that linear causation. Because if we didn't have any knowledge, we'd still be saying, doctor, I'm feeling forgetful. What do I have? And the answer would be, you're feeling forgetful. You're feeling forgetful according to Dr. Alzheimer's. You're feeling forgetful according to the guy that found Lewy bodies. Do you see where I'm going with it? So you're going to say something like, oh, Rod, how about the family history, the candidate genes, blah, blah, blah. Here's the thing. Find the one group of factors that are sufficient, that are necessary and sufficient to justify a given syndrome, and I'll give that to you. I'll absolutely give that to you. For example, you could find the gene related to the little clock we have in our brains that tells the difference between brief psychotic disorder, schizophreniform disorder, and schizophrenia. Because roughly the difference between those is less than a month. The other one lasts from 1 month to 6 months. And then schizophrenia lasts more than 6 months. So find the one gene that is the difference between the three of them. So when you see someone for the first time having psychotic symptoms, right, you can actually say, well, let's find out if that's schizophrenia, brief psychotic disorder, or schizophreniform disorder. Let's order that one lab. Perfect. We may need other labs to tell the difference between a psychosis associated with this putative, right? Like, we want to believe there's an underlying condition. We have no evidence of it, but we want to believe it is there for schizophrenia versus bipolar or depression with psychotic features. We really don't have that. But by the time we do, I'll shut my mouth immediately. And then here comes what breaks my heart the most is, if I told you all these things right now, like, this is what DSM is. You go to a mechanic and you say, my car is making a choo-choo-choo-choo noise. And the mechanic says, oh, I know that is. And you say, what is it? Well, the problem is that your car is making a choo-choo-choo-choo noise. That's really not the point. Diagnoses are not just a name for a description of things. We would hope diagnoses are, okay, what's wrong with your car is this piece is broken and that's why it makes a ch-ch-ch noise. But we don't have that yet. What breaks my heart about all of this is that if you have heard all of this so far without an emotional reaction, a negative emotional reaction, that means that whatever I'm going to say next, which is to present alternative ways to make diagnoses, you probably already got there. But if you have had a negative emotional reaction, because unfortunately most of us were misinformed during our training, then likelihood I already lost you as a listener. But let's continue. So let's take a look at what DSM says. So DSM says the symptoms contained in the respective diagnostic criteria sets do not constitute comprehensive definitions of underlying disorders. Rather, they are intended to summarize characteristic syndromes of signs and symptoms. Good. And if they had stopped there, that would be great, because the clarity that we don't have diseases in DSM would be like, welcome. Instead, they continue. And to be honest with you, if they had done that, I wouldn't be doing this. They say, they continue that phrase. They say, rather, they are intended to summarize characteristic syndromes of signs and symptoms that point to an underlying disorder. And that commitment happened between DSM-3 and DSM-4. They started to believe, don't want to discuss again why, that, not believe, they started to share their desire to believe it. To fix that statement, they could have said, that those symptoms point to an underlying disorder that we wish to believe is there somewhere, but so far we have not found it. We really wish to believe that our diagnosis, at some point, right, we wanted to believe, at least I did, that depression has a unique underlying biological process that is common to everybody that feels sad for more than a month or so. Even though the premise is absurd, I wanted to believe that. So what do we do with that? What do we do with the information, with the fact that DSM is a collection of fibromyalgias. It's just a description of presentations with no absolute link to biological, at least, known underlying mechanisms. We continue to use it, first of all, right? So we can send a bill. But in order to help our patients, we can use actual diagnostic strategies that are borrowed from psychology, because they have been looking to this thing for 100 years, and their success rate with way less side effects has been proven. So those are the legacy of different school of thoughts, and nothing really prevents us of using them. The main difference between the different schools of thought in psychology is either the angle, either the words, or finally what they describe as the actual reason for the problems they see. For the most part, goes on angle and from where they're looking, and the words used to describe it. There's not a lot of difference. If anything, there's a lot of overlap between what different schools of thought will believe the problem is. There's a whole lot of overlap, much more than anyone would ever guess. So, for example, DSM will see two different men and say, okay, this guy is meeting criteria for major depressive disorder, that guy is meeting criteria for generalized anxiety disorder. Psychology would find out that them both have the same diagnosis because all symptoms started once they lost their job. One guy became depressed, the other one became anxious for different reasons. Losing the job is the actual diagnosis of that presentation. And not only is a better alternative, it actually points to the solution of their problems, which is to help them figure their money out. So the depth of those diagnoses in psychology varies tremendously between different schools of thought in psychology. So I'll give you one example, okay? This is a fairly real example. I change always a few things, I change things in the case, but I preserve the core of it. So picture this. This would be a psychological diagnosis that any therapist or psychologist that's worth their salt would reach in a case like this. A teenager, she's like 14. She has been isolative, like not talking, lives only with her mother. There's just the two of them. They don't have anybody else in their lives. She has been feeling indifferent to things. She's not doing the things she used to do for fun. Really not motivated for a lot of things. Whole lot of irritability. Sort of a whatever kind of a take for things. And she's giving hell to her mother at home. And fairly refractory to her mother's efforts to discipline her, like taking her phone away, taking internet away, all those things. She really doesn't care, goes to her room and just sits there. Now, we could call it another factor. 2 years ago, her grandmother died. So that was the three of the girls, grandmother dies, now there's two of the girls. Tough times. So DSM would say, bereavement stuff, maybe would call major depressive disorder, not really sad, kind of a pissed and anhedonia maybe. Now, psychology a psychologist, a therapist, really worth their salt. They also need the diagnosis because they have to bill for the time they spend helping these folks. So it's fair. Just freaking bill it. Use the DSM. Use the DSM for description. That really has nothing to do with the cause, but go for it. Who cares? We need it. No way around it. But the story behind this is, once grandma died, it was really tough on the mom. And the mom, as a result of that, became emotionally unavailable for the daughter. Now, the daughter is also suffering, but the daughter's mom is still alive. My patient's mom is still alive, right? But because of that detachment, her mother didn't honor her maternal duties because she couldn't, because she's absolutely alone now. She has no support from another adult in life. It was just too much for her. The girl becomes resentful. And that resentment translates into something like, my mom is not going to see me doing well. It was so bad that her mother stopped celebrating Christmas because, in her own words, it would be something like, well, Christmas lost its meaning since my mom died. But the girl's mom is still alive, but she don't want to play ball anymore, so the girl becomes resentful. Why? Because you cannot be mad at someone like that lady because she's going through a lot. She has no one. She lost her mother and she has no one. You cannot just be mad at her, so you suppress it, you become resentful, and she's never going to see me smile again. I really don't care about anything. The mother, on the other hand, is also pissed at the world because the world took her mother away and gave her nothing. So she does the same thing. She's resentful of the world and she says, damn it, world, you're not going to see me smiling. Like someone who's pouting in a couple, right? I know, terrible. It was bad. I shouldn't have used that analogy, but I just, bear with me for the meaning behind it. The reason I use those analogies is that you can see that it's not far-fetched that we react by suppressing emotions around people we love but we're mad at, and we become indifferent at things. A case like that, so that is an actual diagnosis. That is the actual diagnosis and points towards a resolution. Now, a lot of work, but a case like that shows up at a clinic to see a shrink, leaves the place with a diagnosis and an antidepressant. And when you look at this way, you realize the complexity of it and how unlikely it is that an antidepressant will make a dent. And not surprisingly, our resolution rates with drugs are very small. We could have made this formulation in purely psychodynamic terms. We could have made it in purely Skinnerian terms. We could have made it in purely systemic psychology terms. But we also can make it in lay terms. I don't have to say reinforcement, rule, govern behavior, to explain the whole concept of resentment. I don't need to talk too much about suppression. I don't need to talk too much about melancholia to use the psychoanalytic thing. I can just describe what I'm seeing. Now you're going to say, wow, geez, Rod, how do you get there, right? How do you get to see those things? We don't have that much time. We have like a one full assessment. How did you get to talk to the mom, to the baby, to the girl, and how do you address that after? Again, I'm privileged, but how do you address people with short follow-ups? And the answer is you can do it. It's better than what we do now by far. But my job is not trying to convince you of that. So instead, I'm going to present an easier guide for psychological, so to speak, diagnosis. That instead of focusing on the way people feel and try to change that with drugs, we actually take emotions for what they are. And what emotions are is they're intangible. we really cannot change emotions successfully and sustainably. We can't. It's not a sustainable way to change emotions with medications. By now you know that. You know what happens if you change emotions with benzos. You have to increase the doses and you cause a whole lot of other problems. You cannot change emotions with antidepressants, because what happens is the patients come back and they say, I'm doing better, and then they come back and say, I'm no longer doing better, and then increase the dose. They come back and say, I'm better, and then they come back and say, I'm not doing better, because the brain is a smart machine that likes to bypass the chemicals we throw at it. So you build up this tolerance to drugs that are emotionally numbing, and the same problem is going to happen with our mushroom fever. Eventually the brain going to get over this thing, and we may end up paying a very high price. I don't know, and I'm not against it. I still repeat, people think at my work, they say, oh, Dr. Darby doesn't like drugs. No, I love drugs. I freaking love them. I love them so much that I know that to have the impact I want them to have, I cannot prescribe too frequently. I really like the impact of drugs. I smoke a cigar every so often, maybe once every 2 weeks. Why? To keep the impact as if it was the first. Most of us do the same with alcohol. If you start drinking alcohol, the impact is over. If you start drinking alcohol every day. So you drink alcohol every so often and it feels freaking amazing. I don't dislike the drugs at all. I just think we should be looking to the problems as they are, identifying the challenges as what they actually are, and then we look at the drugs and think, can this drug help this patient overcome this actual challenge in life? So what challenges in life would that be? So I'm going to show you now is an amalgamation of virtually everyone in psychology, but I'll just say a few names. Jung, Hayes, Seligman is the latest, Bruce Alexander. There's even a biologist called Peter Sterling, and also a lot of evolutionary psychology. That is probably the root of everything we have been doing that is good and effective these days. But I'm going to go with Martin Seligman. He summarized what other those even Maslow hierarchy of needs. So Seligman summarized what those other guys put together in the following acronym: is PERMA. P stands for positive emotions. E stands for engagement in life. R stands for relationships. M stands for meaning, and A for accomplishments. Now, I also sprinkled some stuff of my own in this thing, and that's novelty. And the reason I added novelty, it's because everything grows old for us human beings real quick. Amazing things grow old. We call that hedonic adaptation. That's a name for the phenomenon. It doesn't mean it's not a diagnosis. But everything grows old, and I have seen too many cases of people that have had all those things, relationships, engagement, and things like that. But their lives were too stable, and they started to develop this sort of a malignant boredom. And of course, I saw that myself because I suffer a lot with boredom. Small amounts of boredom drive me insane. So I'm probably more attuned to perceive those things as a personal trait, but has been proven itself very helpful and successful from a therapeutic perspective for me to see that. But let me ask you this. Have you had a patient who didn't have a bad life, but was living a very stagnant life? Or a bad life, but above all, very stagnant, like living a sort of a zombified life. And then something bad happens, medical diagnosis or something bad to someone in the family, and that person, even though reports feeling upset with it, all of a sudden looks alive. So, I have seen that way too many times. My first gig as a psychologist in Brazil was working with patients that had the diagnosis of cancer, and as soon as the diagnosis would kick, I have seen too many times people feel euphoric. I know it sounds crazy, but there was this activation. We have a problem to solve. Let's get over it. And also family members will be panicked, euphoric. There was movement going on. I have seen people lose their jobs after struggling with depression for years, losing their jobs that they allegedly liked, and then they will show up actually awake, actually optimistic, or all of a sudden be activated by a problem that someone in the family is suffering. So that is my stuff. From an amalgamation perspective of all the things that I just told you so far about the positive emotions, engagement in life, relationships, meaning, and accomplishments. So Jung used to say, for example, that their patients were lacking from a lack of meaning, were suffering from a lack of meaning. From an evolutionary perspective, we survived because we were wired to anticipate the next challenge, the next problem. If back in the day, human beings would just wait after a meal to start looking for food when they were hungry again, we probably wouldn't be here. So we are probably wired to find things, find problems, and overcome them. And that covers meaning, because you're chasing something, covers accomplishments, and obviously covers engagement in life. One way to look at this is, what kind of patients have no life whatsoever? Because here's the argument. If you are wired to do something, okay, and that's kind of something that a guy called Peter Sterling, he's a biologist, said. Brilliant thoughts. The things he says are brilliant, and I think the implications of the things he say go beyond even what he wrote on his papers. But if we are wired to do something, and life doesn't if we are wired to solve problems and achieve things, but life is very comfortable, is it too far-fetched to say that we're going to start making those problems in our heads? And if you don't have an obstacle between you and a goal, meaning an engagement in life, if you don't have obstacles to overcome, achievements, is it too far-fetched that you're going to make up those obstacles in your head? And the extreme example I like to give is OCD, where life is absolutely absent, but the amount of problems that someone is solving in his head on a daily basis are absurdly high. So, and by now you're probably thinking, wow, Social Security disability is a trap in that regard, because it keeps you from living life and really doesn't help at all with the problems that got you there, especially if you're getting Social Security for neurotic diagnoses like depression, anxiety, PTSD, and things like that. So that's a framework, that's a diagnostic framework that you can use in clinic. That is, it doesn't require a lot of depth in hours. A case like the one I described would be, okay, so what is the diagnosis of those two girls that are living alone and resentful, one from life and the other one from mom? Well, the diagnosis, they don't have enough relationships, they don't have enough support. So mom died and my life is over. Well, that's something wrong with that, because I would hope your mother didn't raise you to be fully dependent on her. And, anyone would say, well, let's honor the memory of this deceased lady by living meaningful lives. Happy, if you will. I use that word. But nevertheless, live life. But then they stop, right? And then, so the diagnosis in that sense would be their lack of relationships. So when you look at a patient that is presenting with depression, that is presenting with anxiety, or PTSD, or OCD, or things that involve chewing on things from the past, you can say, okay, Do they have enough positive emotions? No. How do you get positive emotions? Doing the things that cause positive emotions, right? Are they engaged in life? No, they are hiding from life. Do they have relationships? No. Do they know where they want to get? Do they have a meaning? No. Do they have, as such, they don't have any small accomplishments. They're not conquering anything. And finally, also look at your cases to see if they have enough new things in their lives. Because when they don't have enough new things, we end up replacing that with our small mad tweaks. The patient comes, there's nothing going to happen, there's no reason for hope or anything, but we increase the Zoloft. Okay, so that's a novelty. He comes back a week later, so well, I'm a little bit better, and then a month later, wins off. It's old. It's not new anymore. So it doesn't look like very sustainable to cause all those side effects just to give some hope. When in actuality, we could be giving hope by telling the truth and saying you are living an unlivable life and you don't have the very basic emotional needs that all these authors that I listed agree you need. And the hopes that I'm going to make you feel better despite all that deprivation, it's quite a silly hope. And we're going to fail miserably. And as we fail, you should feel worse because we are running out of fake chemical options. But then your patient says, well, I think I can do something. I think I can talk to my friends, but I feel very anxious. Oh, okay, we found a roadblock. I have a drug for that specific moment where you're going to feel anxious. Well, then I could actually go back to work or work under the table or do something, but I can focus. I have a drug that can help you with that. Well, I like to have a relationship, but I have been having erectile dysfunction. We can help with that. That's where the drugs take a place. But now we are addressing a real diagnosis, not just a description. We're not just saying, well, people come to you and say, well, I'm feeling sad and I can't sleep and I don't have energy and I don't have motivation and I don't enjoy things. What is it that I have, doctor? And the answer we give is, well, you have sadness, insomnia, lack of motivation, anhedonia. That's it. Impaired appetite. When we give a name to what people tell us, that's no different of just repeating the things they told us. That's not a real diagnosis. But take that frame, PERMA plus novelties. Take that frame by the Seligman. I think I really like that summary. Dr. Hayes talks about values-based life and meaning. He also talks about engagement in life a lot. He has a beautiful book. I interviewed him about that called Get Out of Your Mind and Into Your Life, which I think that's why I wanted to use as a canvas, despite this guy he's a prolific writer. And I recommend any ACT books, Acceptance and Commitment Therapy, ACT, that you find ahead of you. You're not going to regret reading. It's going to help your clinic a lot. But if you feel, psychology is way too complicated, well, use this framework to make diagnoses. I've been saying that for a while. These guys have been saying that for a while. And it's easy to sound like a crazy person in the world of psychiatry. It's obvious in the world of psychology, but in the world of psychiatry, becomes controversial for some reason. Well, we are being vindicated. A few weeks ago, I believe, the Surgeon General issued a report on loneliness, calling loneliness a public health concern and pointing out how loneliness, isolation, accounts for a lot of health problems we have, which goes along what Dr. Peter Sterling said, the biologist that talks about allostasis. But he talks about many more things. And how loneliness is also a causative agent for depression, anxiety, heart problems, premature death, etc. I hope you liked this episode. Please share with colleagues if you think they could benefit from it. Comment, send me an email at info@nepmi.org, and see you next week.